All right, this is segment number 3. Got 2 already, and I try to start with the slide that I left off. So that's where we finished. And now we're continuing to look at our lab abnormalities. Hematocrit, generally, it can be increased or decreased depending on what's going on. If the patient's profoundly dehydrated and they're not bleeding, then you might see it go up. If the patient has a hemorrhagic pancreatitis, then their hematocrit may go down. You're going to see a moderate leukocytosis. Now your liver function tests, those are going to be normal usually, unless there's also biliary dysfunction. You might see the bilirubin slightly elevated, and of course with that you'll see the jaundice. But those are, LFTs are generally normal. The abdominal x-rays or ultrasound, you'll see isolated dilation of a part of the intestine because of an ileus. Patients who have pancreatitis, especially severe, they'll generally have an ileus. You might see gallstones if that's the reason why this patient's got a pancreatitis. A CAT scan, there you will see changes that are going to parallel the degree of inflammation. It's best to do a CAT scan of the abdomen with both oral and IV contrast to better delineate the organ. The MRCP is a magnetic resonance imaging exam of the area, MRCP. If normal, you will not see bile ducts. They do these sequences to see if there are like no flow states. They can see if there are stones or obstructions. The MR sequences can also show if there's a tumor. They can also show pancreatitis, but the CAT scan is still the better diagnostic tool for the pancreatitis. The MRCP might show you why this has occurred. Now we're going to look at some complications. A pseudocyst is a cavity that surrounds the outside of the pancreas. It's going to have inflammatory exudate in it, pancreatic enzymes that are formed on the pancreas. If a patient has a pseudocyst, they'll again have abdominal pain, and you can actually feel an epigastric mass. The patient will have nausea, vomiting, anorexia. Serum amylase levels go up. Usually resolves spontaneously within a few weeks. It can change to an abscess if it becomes contaminated, or if it breaks, it can cause peritonitis, and that's a problem. Now, a pancreatic abscess, like I said, it may start with a pseudocyst, but a pancreatic abscess can develop from bacterial contamination of the exudate and the necrotic area. The origin of the bacteria is not going to be specifically known, but most likely it's GI. A very tender abdomen, a palpable mass, very febrile, white count goes up. There is no data to support the use of a prophylactic antibiotic, but if the patient develops pancreatic abscess, it will be fatal if it's not drained and treated. So this patient will go down to have a drain placed to get rid of that. Moving on with complications, and these are complications, 20% of pancreatises end up being this severe kind, but they're not all going to end up with, not all pancreatises end up being severe. So you can have multiple organ failure. Bacterial endotoxins during an acute pancreatitis attack, bacterial endotoxins, your pancreatic proteases, and other agents, they can be released into the systemic circulation, and that will activate the complement system and produces symptoms in other organs, like adult respiratory distress syndrome, which is a phenomena that causes significant pulmonary edema in the lungs that's not related to fluid overload and to heart failure. Rather, it happens because the alveolar capillary membrane becomes super permeable and allows all kinds of leakage into interstitial spaces. And we'll do ARDS in the 4th semester. Just know these patients will be intubated, ventilated, and they have a very prolonged course because now their lungs, not only do we have to get them over the pancreatitis, but their lungs have to go through a healing process to get over this. Mortality for ARDS is pretty significant. Renal failure is another possible complication. These endotoxins and stuff released into your circulatory system can cause your heart to be depressed. So the patient can have heart failure because it isn't working well. You can end up with a DIC, which is disruption in the normal coagulation abilities of your body. The hypocalcemia can produce tetany and rhythm disturbances. You know, if you guys don't have a good handle on fluid and electrolytes from AC1, that really is a place to start. You absolutely have to bring that content with you into the 3rd and 4th semesters. It underlies so much of what we do. When the patient has complications, the mortality goes up. With an edematous pancreatitis, the mortality is about 10%, 20% or greater if they have a hemorrhagic pancreatitis. Recurrences are common for patients who have pancreatitis, particularly if you consider the etiologies of biliary disease and alcoholism. Those have to be addressed. The objectives of collaborative care: we're going to relieve pain. We've got to prevent or alleviate shock. You want to reduce pancreatic enzymes. You want to make sure the patient has fluid and electrolyte balance. And you want to remove the precipitating cause. So, aggressive hydration. If needed, we'll use plasma volume expanders. You want IV fluid replacement with appropriate electrolytes. You need adequate to maintain a circulating blood volume and urine output. Whatever it takes to maintain a urine output of greater than 30 mils an hour, provided the patient doesn't already have renal failure. Pain management. Still under fluids and electrolytes. You want to assess the fluid and electrolyte needs. Remember that large amounts of fluids and calcium in particular can be sequestered in your retroperitoneal area or in the peritoneal cavity. The patient will need to be MPO, absolutely, because of vomiting. Also, they'll have an NG tube, and that NG tube and the vomiting can affect their fluid and electrolyte status. The reason for NG tube is to minimize the secretion of these pancreatic enzymes. You know, when you eat, the pancreas is stimulated to release its enzymes into your GI tract. But the problem in pancreatitis is before the enzymes get to the GI tract, they're being activated. And so we want to keep that pancreas really quiet. Blood transfusions if they have hemorrhagic pancreatitis. Pain meds are going to be a priority. Narcotics like Demerol. Now, the book says morphine and Demerol, but Demerol is going to be the drug of choice. The morphine stimulates contraction, or can stimulate contraction of the sphincter of Oddi, and probably should not be used. Antispasmodics, which are your anticholinergic drugs, are also used. All right, I'm going to stop with this segment.